The time is now noon, so I am just going to get started with some housekeeping items. I'm sure more people will trickle in as we continue. But my name is Bridget Sweeney, and I'm the training coordinator for the Maryland Addiction Consultation Service, also known as MACS. And I'll give more information about our program in a little bit. But beforehand, I do just want to let you know that for today's webinar, we will be offering CEUs and CME credit. To receive CEUs, you do have to stay on for at least 45 minutes. We cannot, unfortunately, due to the rules of CEUs, we cannot offer any partial credit. And for both CEUs and CMEs, following today's webinar, you will receive a link to the evaluation survey. Once you fill that out, please allow 1 business week, but we will email you your certificate of credit. You will also receive a copy of the slides to the email that you registered with today, and that should also come by the end of the day today, so look out for that. Other than that, if you have any questions about this process, please email me. I know I sent out the WebEx invitation. I'll also be sending out the slides, so feel free to just reply to that or start a new message with me, and I'll get back to you as soon as possible. Now to give you an overview of MACS. Like I said, MACS stands for the Maryland Addiction Consultation Service, and we are here to support you as providers. I will put our contact information into the chat, but our services are completely free, and they include a phone consultation warm line, open Monday through Friday, 9 to 5. And you can call that line with clinical questions. They can be as patient-specific as you'd like, as long as you give us the identified information. Our behavioral health consultant will kind of screen your call, get some more information about what you are looking for, and we will connect you with the appropriate consultant to answer your questions. I put that phone number into the chat. Our other services include training opportunities, such as today's webinar. They're usually during the lunch break to accommodate you. All of those are free, and we have a wide range of didactic topics. We also love to hear what topics you would like to see, so that information will also be collected on the evaluation survey. And I see we have a couple more people join. So once again, the evaluation survey and copy of the slides will be sent out immediately following today's webinar. Thank you all for joining, and happy Nurse Practitioner Week. We had the pleasure of having Marian Kearns join our consultant team and thought this was a great opportunity to engage with nurse practitioners as well as honor them during this week. As I mentioned, Marian Kearns is a clinical registered nurse practitioner and is presently the director of the University of Maryland Medical Center Midtown Campus Center for Addiction Medicine, also known as CAM. As the lead nurse practitioner, she manages the medical and behavioral care for the inpatient and outpatient chemical dependency service. Her care for patients with substance use disorder extends from inner city Baltimore to the rural areas of Maryland. And under her management, CAM has grown to include multiple levels of care while maintaining Joint Commission certification. Marian is also the co-advisor to the newly developed ASAM NPSUD Med Ed project. This is an in-depth online nurse practitioner curriculum for substance use disorder training in 10 universities throughout the United States. And Marian participates in the University of Maryland School of Nursing Advisory Board for Addiction Education. And she is the first nurse practitioner, and this is the first DMP addiction specialty certification for the School of Nursing. Marian is also the co-chair of the opioid task force for the University of Maryland Midtown. And as I mentioned, we are grateful to have Marian as a consultant, and she is a great example of someone you would be connected to if you do call our warm line with patient-specific questions or general questions about substance use disorders. Marian, I will turn it over to you. I know that I muted you earlier. Let me know if you need any help unmuting, and thank you for presenting today.
Okay, can you hear me now? All right, good. Well, you'll need a glass of water after all those words. I want to thank Bridget very, very much for helping me get through this, my first time in actually doing a MACS presentation in front of everybody. So thank you, Bridget, for helping me get through this. And thank you for everyone for being on this presentation today. I was asked to speak about the role of the nurse practitioner in the treatment of substance use disorder. And I'm going to go over the learning objectives. So we're going to talk about how to identify nurse practitioners in their increase in their confidence and providing quality care for patients with substance use, recognize the methods to maintain professionalism with our patients and colleagues, and describe how to maintain professional standards of practice within the guidelines, and also a whole bunch of other things that I just think are going to be fun. So we're going to try to make this a good presentation and understand that for myself as a nurse practitioner, when you have to say, how many years have you been in a nurse practitioner? It's always the bottom one, more than 40 years here as a nurse practitioner. So I want to, again, echo what Bridget said. Also, it is Happy Nurse Practitioner Week. I'm very excited to be a nurse practitioner and be part of the MAX. Nurse Practitioner Week is November the 13th through the 19th this year. And one of the quotes online is nurse practitioners are a critical part of the nursing practice and the entire healthcare team. So want to be able to give you the first quiz for the day. So what year was the first nurse practitioner training program ever started? You can put it in the chat if you think you know. But again, was it 1945? Was it 1965? Or was it 2004? Just to let you know that it was 1965 is when Loretta Ford partnered with a physician, Henry Silver, to create the first training program for nurse practitioners. Their program was offered at the University of Colorado and focused on family health, disease prevention, and the promotion of health. So I was very impressed with those words because it's very much what we do today. We focus on the family, we focus on disease prevention and promotion of health, especially in the substance use disorder world. So we've been around for a long time, but we weren't celebrated. In fact, we had a hard road being nurse practitioners in the world and in the medical community. So it took us a while before we were actually really recognized. So given that, can anybody tell me what year we actually were recognized as nurse practitioners in our field? So it is celebrated the second week of November to recognize the incredible work that we do, to raise awareness of the powerful role they play, and we as nurse practitioners play in the general health and well-being. So we've been in existence for 57 years. And so, yes, you're right. It's 2004 is when we became recognized as nurse practitioners. And in my world, 2004 wasn't that long ago. What I'm going to talk about today is the role of the nurse practitioner. And one of the roles of the nurse practitioner is actually to be informed, to be well educated, and to continue that education. I was really lucky as I was voted to be the chair of the volunteer committee at the ATOD conference in 2022. This was a huge international conference that we had right here in Baltimore, Maryland, just in the beginning of this month, the beginning of November. We were 1,500 strong, and we named our conference The Power of Collaboration. So when I was thinking about our topic and what could I do to identify with my fellow nurse practitioners, physicians, and PAs on the call, I guess I wanted to be able to say that our big strength, the way I see it, is our power of collaboration. And what we did at this international conference is we worked on bringing many people together, many entities. I just listed a few of them here so you could see all the participants that were at this local conference here in Baltimore, from our national ATOD to the Federation of Opioid Treatment of Opioid Dependence, to MATOD, which is our Maryland chapter, to the ONDCP, to SAMHSA. Many of you know a lot of these letters already, including the DEA, our Maryland OOCC, our state Baltimore Behavioral Health Administration, and BHSB, and even the Legal Action Committee and the American Nurses Association. And they were only a few. And the reason I gave you that list was that look at all the people that nurse practitioners and our substance use disorder have in common. So we all got together. We had collaboration. And when we made, so my takeaway from this whole conference was that collaboration is at every level. It involves policy practice. And if you remember back the slides I just said, when we became nurse practitioners, it wasn't always legal in the beginning. We had to go to policymakers. We had to get legislation. Our local group worked to be able to get nurse practitioners to write prescriptions, because when I became a nurse practitioner in the beginning, we weren't even allowed to write a prescription, much less a narcotic prescription. So becoming active in your local policy and your national policy. Being part of the national policies, there's our group, our nurse practitioner group is actually working, and our MATOD group is working on a national level to have input into the new national policies that are coming along in 2023 that will significantly change how we treat substance use disorder in national arena of our care. So look forward to some great things coming up in the summer of 2023. Media makes a difference. At our ATOD meeting, we had media from the New York Post to the local Politico. We had patients get on camera to be able to show how they make a difference. And it was very impactful. The other thing that I learned, the power of collaboration, was that fentanyl is in the United States and Canada. And there's many new analogs that are coming along. And we needed to learn these new analogs and learn how to test for them. And that's what makes us great, because we're on the cutting edge. I also learned that fentanyl is not really in Europe. That was pretty new to me. But nonetheless, they think it's coming to Europe eventually. But our American people like our fentanyl, and it's an easy access to our US and Canada friends. So we need more access to treatment. And I bolded that because that was the theme throughout the entire conference, is our collaboration and our need for more access to treatment. They even talked about the law it is that substance use disorder is mandated in all the federal jails of methadone, buprenorphine, and naltrexone. It's not always been implemented, but there's some trials and tribulations to each one of the behind the walls areas. But I know that's coming soon, and hopefully that'll be another collaboration process that will get treatment for our patients. Another big topic we talked about was harm reduction. There's a lot of different philosophies on harm reduction, what it means, how we implement it. So look forward to me coming back in the spring and doing a harm reduction conference for us in more detail. The other part of the power of collaboration I wanted you to understand from me, it really was really impactful at the conference. When we talked about the community providers, we as nurse practitioners have to really cooperate and collaborate with every entity that our patient is involved with. We need to recognize the methods that we connect with our patients, both and with their providers, the primary care providers, the pain management providers, their counselors, therapists, peer recovery co-specialists, and even any specialty providers. And we as nurse practitioners really have to be on the forefront of making sure our patients know that we want to have that collaboration. It's not to be able to get you, it's not to be able to squeal, it's not to be able to be punitive in any way. It is to have the collaboration needs to be our mantra in the care of our patients. With the release of information for any new providers, healthcare providers, and assure that the patient knows that this is all collaborative. I would be remiss if we didn't talk about the collaboration between the mental health providers and other specialty clinics. So, and for me, I always wonder why some providers write prescriptions for our patients. And we go, why are they writing these prescriptions for our patients when they know the patient has a substance use disorder? But I'm just reminding people here that when a patient belongs to an OTP, an opioid treatment program, and dispenses the methadone or buprenorphine or naltrexone, those medications don't show up on our CRISP. They don't show up for the providers in the community. So that's why it's really important that we have a good collaborative agreement with the mental health and the specialty providers to have an understanding between the two, the patient, between the three, the patient, the nurse practitioner, provider, and the specialty level. And again, the collaboration goes even further. We talked about national, we talked about local, we talked about providers. We need to also talk about the families. Know your community resources, where you can send your patient to. Know that the family is a major part of your patient. Know who the emergency contact is. Obtain the release of information on admission from the very first day. We have to know our patient, get the releases signed, have them in our chart, have them updated, and include the release of information for significant other, peer recovery coaches, as I mentioned, or other people that are involved with the patient. I do a lot of telehealth. When we're doing, we do teleport here. When the patient's on the phone, sometimes you see the family walk by, you see the pets walk by. That's a good way to collaborate and connect with your patient. It makes the patient feel involved, but again, we want to make sure we have the collaboration and the cooperation of the patient. One of the things that makes us really great nurse practitioners and providers also is our ability to collaborate with the pharmacies. It's recommended that if you're going to be writing prescriptions for our patients or your patient, that you prescribe the prescription, that you send the prescription to a local pharmacy, somebody who you can connect with if possible. Sometimes the patients want it at their pharmacy, and that's okay, but just try to get to know the pharmacist. Had a patient that I wrote a prescription for buprenorphine just last Friday, and the pharmacy called me back up an hour later. Hi, Marion, how you doing? Do you know this was going on with the patient? Yes, I knew this was going on with the patient. Okay, as long as we know what we're doing for each other, we're helping each other. So we had a good collaboration with the pharmacy. They knew each other we know each other by name, and it really helped us to make sure that the patient's getting quality care. Verify your CRISP every day. I was just on the phone with one of my colleagues who's on the call today. CRISP is making some major changes this week. It's going to change dramatically. So go to your CRISP, look for your email today from the CRISP company that's going to help you to change over to the new unified landing page. One of the challenges that I have as a nurse practitioner when I do look at CRISP, it does have some discrepancies. So what I do is when I have a discrepancy, I just don't ignore it. If I see something, I say something. I pick up the phone and call the pharmacy. What happened? I know I wrote this prescription, the patient got it filled, but I don't see it on the CRISP. And it helps them to be aware. Sometimes I call CRISP themselves and say, look, I'm having some challenges. And they go and they make it work. Because we, again, have to make sure we get our patients to have the quality care. And then the collaboration goes all the way down to the patient level. You have to take care of your patient, have compassion. In our particular electronic health record, we have something that's called a storyboard. The storyboard's fun. I always write, every time I see a patient, I try to add something else to the storyboard. The storyboard talks about what makes the patient happy. What's the patient do for a living? What's their nickname? What is that patient working on at home? Have a patient who said she's been a little bored lately due to COVID. I said, what did you used to do? She said, I like to paint rocks for my garden with my grandchildren. So we said, okay, so the next month, and I wrote it down on my storyboard, next month she gets on the phone and I said, hey, can I see the rock? She says, I was really hoping you would ask. And she picked up the rock and showed it to me. The connection that we made with this little patient care connection, that collaboration, made all the difference in the world to her. So know your patient, build that connection, be a well-rounded provider, and add that personal touch. Had another patient, as I said to you, that on Friday there was a problem. So I called her back up. Hi, how you doing today? It's not my time to call her. She didn't have an appointment, but I was just touching base with her. And she said, I couldn't believe that you called me, Mary. It's not our day, but I'm so glad that you care. So again, it's that collaboration and that patient care touch that we as nurse practitioners and providers have. This picture comes from Max, and it says it all for me. Actions speak louder than words. People need to see that you care before they care what you think. You've probably all seen this picture many times, maybe, but to me, it's important that from before the patient even walks in the door, you know that you care about your patient, and they see it, they feel it from the very first day. From the very first day, there's also a provider agreement. And I asked Bridget to maybe put in the chat or add it somewhere along. I know you can't read this agreement, but I think from the very first day that you see the patient, you show them respect, you show them dignity, and you also tell them what you expect from them and what they can expect from you. Buprenorphine or methadone is not always for every patient, and you can work with that patient and make a plan. Here's the next question for you. What year was buprenorphine approved for substance use disorder? If anybody knows. The answer is 2002. I'm going to help you here. So buprenorphine actually wasn't approved for substance use disorder. It was around for pain management and still is for pain management, but it's also now used for substance use disorder. In 2002, we were lucky enough to get the Data 2000 became approved. The Data Addiction Treatment Act, which is the Data 2000 Act, was signed by President Clinton, which allowed physicians for the first time in more than 8 decades to provide opioid medications for the treatment of opioid addiction in the normal course of their practice. 2 years later, on October 8th, 2002, Suboxone, buprenorphine, and Subutex, the mono product, received FDA approval for the treatment of opioid addiction. So again, 2002 was a bit longer ago. But what year, from 2002 to what year were nurse practitioners and PAs approved to prescribe buprenorphine? Didn't make you guess at this one because many of you actually know this date, and it's probably hopefully part of your life. And 2016 is when we actually, through the CARA Act, the Comprehensive Addiction and Recovery Act of 2016, expanded those prescribing authority for buprenorphine, for one of the 3 medications approved by the FDA for treating opiate use disorders to nurse practitioners and physician's assistants. So it's important that you understand we weren't always allowed to prescribe. We weren't always allowed to prescribe narcotics. We weren't always allowed to prescribe buprenorphine. So we've come a long way. And the reason we've come a long way is because nurse practitioners were involved. As I said, the collaboration even on a national and a political arena to make things better for nurse practitioners. So, okay, in 2016, we were allowed to write prescriptions. Okay, but what did we have to do? The nurse practitioner had to get 24 hours of education, which was required to obtain a DEA and a medication-assisted treatment waiver for 30 patients. So the physicians needed to get 8, we needed to get 24. And that's still true today if you want to be able to medicate or provide treatment for over 30 patients. So you could do the waiver, see 30 patients. After you saw 30 patients for a year, you could increase the limit to 100. After you had the 100, and if you had many additional services, you could get a limit of 275 patients in your practice. In April of 2021, here comes a new way to be able to help people. It was approved for buprenorphine that you did, a nurse practitioner or a PA or any provider did not have to go through the training. They still needed to register with the DEA. They still needed to go to SAMHSA, and they would recommend that you continue to go forward to get the training, but it's not mandated if you're going to have less than 30. So again, another big step. But what makes nurse practitioners awesome is because they do go for the training. If they go for the training, there's lots of different places that'll give you the waiver training. And I thank you, Bridget, for giving me the list of all the people that are on the web today. There's many people that are not waived that are on the webinar today. So I'm here to beseech to you what we talked about: collaboration, getting access to treatment, and getting the waiver training. You can go through MAX. It's all free. You could go through ASAM, PCSS, SAMHSA, and the APNA, the American Psychiatric Nurse Association, to get your waiver training. Lots of places out there, and they're all free. The next thing I want to say is many people don't understand that. They think that once they get the waiver, they are good to go. And for me, when you want to become a specialist in your field, then you should go on to get further education and become certified in your field. So once you get the waiver training, you can go a step further and become a high quality provider. The 3 places where you can get your nurse practitioner certification. The first one is up and running right now. This is INSTA. It's the International Society for Addiction. They support the certification for addictions registered nurses and nurse practitioners through the ANCBON line. So you can go there and take the test to become certified. There's another local, there's the National Organization of Chemical Dependency Nurses is a group that will be giving the certification probably in January of 2023. I'm really pleased that we also, right here in Baltimore, at University of Maryland, has the addiction certificate program that will prepare you to be able to pass the CARN AP. So consider doing the waiver, getting additional education and training so that you can become certified and be the best nurse practitioner ever in substance use disorder. In doing my review for today, I wanted to touch on a recent article that was written about buprenorphine in the rural areas. And as I said, there's a couple of people on the line here today that are not waivered, and you're not alone. A lot of people have some concerns. So as you see in the second bullet, patients with 30 waivers are treating the average of 13.2 patients. It's only 37% were not treating patients at all. And there are some common barriers that people feel that they're concerned about. They're concerned about diversion and medication misuse, the lack of specialty backup. New prescribers have some concerns and barriers that they have to overcome. So the people that are on the line that aren't waivered, I want you to know you're not alone, but we're here to help you get through that. 216 of MAX nurse practitioners are waivered, but there's still some that are not. And there's 59 of them at the last count that are in the process of becoming waivered. So we want everybody to become waivered and utilize their waiver to treat patients, because if we don't all help a little bit, we're going to have difficulty in reducing the treatment. We need to increase the treatment in Maryland. And to do that, everybody could use a little, take on a patient or two, even in the rural or in the city area, to help our patients get the treatment that they need. Sorry, I got a little tongue-tied there. So the next couple of slides are my extra slides. These are the things I want to remind everybody. I hope that everybody on this phone knows, on this phone conference, the website, WebEx, knows that addiction is treatable. Please, addiction is treatable. person first language. Remember we talked a little bit about in the beginning was when patients need to see and hear that you care. The way that they hear that you care is having the language that matters. The current language focuses on labeling or stigmatizing people, the word abuse. We're trying really hard to get away from language that is stigmatizing. We don't use substance abuser. We use the word person with substance use disorder. We're not the only venue that has to re-look at our language. Look at the football teams. Isn't it kind of hard to say Washington Commanders now? Or the Cleveland Guardians? So we've had to change names of football teams because we're stigmatizing language. Language matters in addiction also. This is one of my slides that I live and breathe by. And here at CAM, we talk a lot about changing our language. We never say the word clean or dirty anymore. Patients who we say the patient is abstinent or abstaining or negative for substances. We don't say, because the opposite of clean is dirty, and we never want to relate to our patients as dirty. So I wanted you to kind of please read this list here and know that we don't say non-compliant anymore. We don't say substance abuse anymore. We don't say drug habit anymore. Those are important words that we have to take out of our vocabulary to make our language healthy. Another one that's not on here is we don't say detox anymore. We say medically supervised withdrawal, just to be able to be more accurate. So yes, it's hard to kind of get rid of the language, and sometimes we sweep it under the rug. Next fun fact I wanted to show is everybody probably knows that fentanyl is the drug in our Baltimore area. They're combining fentanyl and heroin together, but I wanted you to see that this was heroin, how much it is. Fentanyl, it's only a few little grains, and carfentanil, which we have seen in an area, it only takes one little teeny grain. We don't see much heroin anymore, so we do see fentanyl 100% of the time, and we do need to make sure that our urines are tested for the fentanyl. Next picture, I just wanted to show you how the community drug dealers have really learned how to market their substance for us. Rainbow fentanyl certainly looks pretty. There's a lot of other substances in the community that are killing our teenagers and everybody that takes fentanyl because it's so potent. Remember, there's lots of different ways of fentanyl, and sometimes teaching patients about the fentanyl, that it looks so fun to have, can actually be deadly, is really important. The other thing that just came out with every patient who we prescribe a narcotic for, at least in an OTP, we give them Narcan. This is the 4 milligrams. It's naloxone. The 4 milligrams. This Clodoxo, they told me how to say it last week. Clodoxo is the new product that just came out in the last month or two, and this is the 8 milligram. It's a stronger dose of the naloxone for your patients. I just wanted you to hear about it and know that it's around. One of the other new things that a lot of people that I just remind people that came through the Max for Mom is that if you have a pregnant patient, when I first started doing this, if the patient was on buprenorphine and they got pregnant, we would take them off their buprenorphine and put them on methadone. We've come a long way. We've took them off of their combination product and put them on mono product. We've come a long way. Now we know that if a patient is pregnant, we can leave them right on their Suboxone product that they've been on without any changes. The studies have shown that there's no negative outcomes for the baby. The other one that I wanted to show, a lot of us know about the Bupronex, the Bucol, the Subutex, but I want to also remind you that Sublocade is available. We do the Sublocade here in our office. It's an injection in the belly once a month. Many of our patients love Sublocade. They come in, they get the injection, and they don't have to go to the pharmacy. They don't have to get a prescription. They don't have to wait in line or pay a copay for a prescription. And if you're worried about diversion, if you're worried about patients abusing their prescriptions, Sublocade is probably a great alternative for your patient. And again, one is enough for those nurse practitioners and providers on the phone call who might have some concerns about using the buprenorphine and prescribing it for their patients. I want you to know that you're not alone. When enough is enough, every patient doesn't always toe the line perfectly, but sometimes there's some things here that you could do to be able to help your patient get through it. And what I wanted you to know more than anything is I am very, very lucky that here in my office, I have 3 other nurse practitioners and 2 other physicians that work with me, and we can bounce things off of. We have treatment team meetings. We talk to each other. We connect through Epic in baskets and keep each other informed. We have good collaboration. And what I want you to know is if you don't have anybody to collaborate with, if you don't know whether the dose is adequate, you don't know what to do to be able to help this particular patient, then that's when you phone a friend. Max is your friend. It's a free service. You phone us up, you run, I don't care how little the question is, there is no silly question. There's nothing, I can't say there's nothing we haven't heard before because there's always something. But we have come up with some amazing cases. We've come up with really good solutions. So don't have any concerns about treating your patients and know that you've got a friend here in Max. Educational resources. Max has a website. There's Max for Moms, Max Echo. PCSS is absolutely phenomenal also in the educational webinars and the trainings that they have. SAMHSA and ASAM, again, as we talked about. Nurse practitioners are fantastic. Pat yourselves on the back, everybody. Take care of yourself. If you don't take care of yourself, you can't take care of your patients. So take care of yourself first. Take care of your patients. I'll see you in the spring for part 2 of the nurse practitioner and medication assisted treatment. And I will be glad to take any questions that you might have. Remember to give yourself the compassion that you need. Nurse Practitioner Week, thank you, and happy Nurse Practitioner Week until next year.
Thank you so much, Marian. This was such a unique perspective that we haven't had before, so we really appreciate that. We did get one question so far, but I encourage more people to enter them into the chat. But the first question we have is, Sublocade is safe during pregnancy, correct?
So we have not been using Sublocade in pregnancy. It's felt to be safe, but it's dangerous given the injection in the abdomen when the mom is pregnant.
Awesome, thank you. While more people enter questions into the chat, I am just going to enter the Max social media accounts into the chat. Just because we do have other celebrations coming up for Nurse Practitioner Week throughout this week, so we'll be posting all sorts of information that is nurse practitioner specific. So please look out for that on any of our social media sites. And this may be, it looks like someone just put something into the Q&A. Someone asked, what are the restrictions of Sublocade?
Sublocade, for me, a patient needs to be on Sublocade on Suboxone for about 7 days. We want them to be at least 8 milligrams or more for at least 7 days. So we know that they're tolerant of it. Then they come in and we look at them to make sure that they are not. I had one patient who was really cachectic, very slender, and there wasn't a lot of girth to him. So we have to be careful that there's enough muscle and tissue that I can inject the Sublocade in the abdomen. It is expensive, so we have to make sure the patient has the right insurance to pay for it. Medicare Medicaid, here our state will pay for it, no problem. And the patient has to be willing to get a shot in the abdomen, which is a little scary for some people. But once they get the first one, they're usually, let me have it. Let me go back and get another one, because they don't have to deal with any of the medications for the rest of the month. Had one man who went to, got on this Sublocade, and it was amazing. He comes back the next time. He said, Marion, I had to go to the pharmacy to get something else. And there was a man in front of me who was getting the Suboxone prescription. And so the man in front of him got Suboxone. And there was like he said there was like some stigmatizing reaction from even the pharmacist. But when he went up, he didn't have to get a Sublocade. His Suboxone prescription, because he already had it in his belly. He went camping with his children, and he was so happy. He didn't have to take his buprenorphine with him on the camping trip, and worried that the other scouts at this camping trip would see the Suboxone or somebody would find it. It was life-changing for him. He also felt like he didn't have to take a pill every day. Getting rid of that pill mentality really helped him to feel like he was okay. He was more normal, is what he called himself. So the Sublocade, I think it's so underutilized, but we here at CAM, we love it. It really works very well for our patients.
Great, thank you so much. The next question is from Laura Shealy, who is a nurse practitioner in Anne Arundel County. And Laura asks, could you talk more about the certification, because she is interested?
Great. So the certification, so you have to study. It's a test. That's why I gave the educational books and manuals that you can do for your certification. If you go to the website, they actually, have a training guide from ENSTA to be able to learn more, to be able to take the certification. And as I said, the University of Maryland has several credit course here in Baltimore that you can sign up for to become certified. And then when you take that particular course, it's a pretty intense course. I was helping the team at university write a lot of the questions for it. It is an amazing course. You will be a well-rounded provider in addictions. And when you take that certification course at University of Maryland, it will really prep you to take the AP CARN certification. But it's awesome. A feather in your cap, that's for sure.
Great. And if Laura has any other specific questions, we will be sure to connect her to you. We don't have any other questions in the chat, but I actually have a question for you, and I know I'm putting you on the spot, so no pressure. But do you have any examples of, I know you've been on our warm line for a little bit, of maybe cases or questions that have come in that you think just are examples of what people can call the warm line with, or things that you're surprised more nurse practitioners don't ask questions about when it comes to treating substance use disorders?
Absolutely. It is a little intimidating the first time I wrote my first prescription for buprenorphine. Like, do I give them a week? Do I give them a month? Do I give, how do I do that? So I think what I tell nurse practitioners is my mantra in my life is go small and go often. So if you're seeing a patient and you're prescribing the medication, just go small the first day. You don't want to overdo it too much. But then frequently, a couple times a week or once a week, you're going to change that and connect with that patient on a regular basis. And the patient will help you figure out what's best for them. They'll tell you that things are not right or they have a problem. So listen to your patients, have that collaboration, make sure that patient knows very well that they can pick up the phone and call you. One of the people asked me, is like, what's the most important thing that I could tell you? And for me, I'm old school, I guess, but addiction doesn't stop at 4 o'clock in the afternoon at the end of the day. Patients often have problems in the evening or at nighttime or on the weekend. And so for me, I really want the patients to understand they can call me. I give support medicines. if somebody's new at this. The other thing that I didn't mention here, which thank you for asking, what we're trying to do now is to help people transition from, if they're on methadone and they want to get to buprenorphine, there's a whole process. We could do a whole lecture on microdosing and macrodosing, to use the buprenorphine in its intended use, to be able to help patients to get to the autonomy that they need to be able to manage their addiction. By autonomy, I mean sometimes the OTPs, which we have here, is pretty restrictive in its way that it manages its patients. But if you have a patient on buprenorphine, they have a lot more autonomy and capability of doing more sooner than some of the restrictions in an OTP. So for me, the biggest is listen to your patient. They can try buprenorphine, it doesn't work, they can go to methadone, they can go back to buprenorphine, and really help pick the medication that is right for your particular patient.
Awesome. Thank you so much. We had 2 more questions come in while you were giving that answer. The next question is, what do you suggest as management for patients whom you receive an anonymous tip or hearsay that they are selling their buprenorphine?
Great, and it happens. But again, I like the word hearsay. It is hearsay. What we do at our particular office is we do what we call a callback. And that's one of the things that you do when you meet the person on the first day. Hi, these are the expectations. I expect you to use your medication. And what I'm going to do is I'm going to call you and you're going to show me that you have the right medication. What we do here in our office is we have them bring their medication back in and actually do a face-to-face. But I know some buprenorphine providers actually do that on the telephone with their teleport. They'll actually say, here, Brittany, show me your medications to make sure that they have all those medications, because it is a concern, but I'm not as concerned about the patients diverting their medication. It's more about the patients, they're still alive. If they're out using fentanyl, it's not if they're going to have problems, it's when. So we want our patients to take out their medications, take it as prescribed, and we can help monitor them. And if you have some concerns, you just call them up, bring it back, let me see, and see them more regularly. Or, as I mentioned, switch them over to the Sublocade, where that's an injection where you don't have to be and get the medication at all.
Great, thank you. The next question we're seeing here is, what is the best way to induct a patient onto Suboxone right from using illicit opioids or fentanyl?
Great question, and we do it every day of the week. And again, a slow and low for the beginning is you can start with a small dose of buprenorphine, give it to them every couple of hours. There's some philosophy of macrodosing, and that's to do an 8 milligrams, and if precipitate withdrawal, you give another 8 milligrams, but I said my patients don't like me so much, and I want them to like me. So we usually go a little lower and give comfort meds with it. So I try to get them up to 8 to 12 milligrams the first day. Second day, we usually try to get up to 8 milligrams the first day, 12 the second day, and 16 by the third day, just to be able to help them transition to the total blocking dose and feel better as soon as possible. Our comfort meds that we use Motrin, we use Flexeril, we use some clonidine, and we use some trazodone. So I'll actually, if I'm starting a person and trying to do an induction, I'll give the medication for the week of their buprenorphine along with the comfort meds. So if they have any symptoms at all, they can have comfort medications to help them through that first week. But once they get to 12 to 16 milligrams, they usually don't need those comfort meds at all.
Great, thank you. Someone wrote in, I just had that happen with a patient and they were not happy. So definitely a similar experience.
Great.
I am not seeing any other questions in the chat right now. Please feel free to enter them. Since we do have a little bit of extra time, if you are interested in getting your 30 patient level waiver, I'm happy to walk you through that application now. All you would need is your medical state license number and your DEA number. I just ask if that is something that you are interested, please put your name followed by HHS into the chat, and we are happy to do that. But if not, please continue to ask Marian questions, and I will continue to read them out loud to her. She's a great resource to have live in front of you right now, so please feel free to enter more questions into the chat.
The one thing that I would encourage people to do is, again, as we've talked about, we're doing some really amazing things as nurse practitioners. What I really like to let people know that we're also, it's very easy to go from buprenorphine to methadone. It's not so easy to go from methadone to buprenorphine, but it's not impossible and should not make the patient scared. It's the collaboration between you as the provider and the methadone program that we can actually work on the microdosing to get a patient from their methadone to buprenorphine without having to take them off their methadone, because they don't want to stop the methadone. They don't want to feel sick. Nobody wants to feel sick. So we truly, help people to understand that it is easy to make the change, but what is not easy is for the patient to be committed to recovery and maybe medications for as long as necessary. I tell my patients there's, medication in heaven. It's okay to be on methadone or buprenorphine the rest of your life if that's what you need, because we treat our addiction as a disease. And we use the concept of, I don't take you off your blood pressure medicine. I'm not going to take you off of your substance use disorder medication until we really have your life stabilized. And that's really what you want. But we never force anybody to stay on medication. And counseling is really important, to have resources for counseling for your patients that are in substance use disorder.
Awesome. We do have 3 other questions that were just entered into the chat. The first one is, I heard someone mention higher daily doses of Suboxone, up to 24 milligrams. Any comment on that?
Sure, absolutely. I have quite a few people that are on 24 milligrams. You start at 16, you start at 8, you work your way up. Remember I told you, you go start a little small, but you go often. You keep going until you find, and the patient will tell you what they need. And I have no problem going to 24 milligrams for that person who shows me and gives me the objective data that shows that they need medications to that particular dose. So I don't have, I guess it's about maybe 15% of my patients who are on 24 milligrams of buprenorphine. So it's not everybody, but certainly those that need it. Absolutely.
Awesome. Thank you. The next question is, so would the method of switching from methadone to Suboxone be the same thing as going from illicit opioids to Suboxone?
Correct. But here's the big difference. You don't stop the methadone. If they're on methadone 80 milligrams a day, they keep taking their methadone 80 milligrams a day, and you give slower, low, teeny doses of buprenorphine the first day, along with comfort meds. The second day, a little bit more. And by the end of the week, they're up to 8 milligrams of buprenorphine, or 16 if you can get them up that high. And most people do. Then you can stop the methadone and continue with the higher doses of buprenorphine. I have to say that I've only done it 3 times. Patients like their methadone and they're stable, but all 3 were successful.
Great, thank you. I know we're throwing a lot at you here, but we have 2 more questions in the chat, if that's okay with you. The next question is methadone going away, and how are the decisions to switch made?
Is methadone going away? No. Methadone is not going away. And as I said to you, there's some major changes coming in methadone that our nurse practitioner group has and MATOD has been involved with on a national level. So those national guidelines haven't been updated for 20 years. So they are redoing the guidelines, and we're looking forward to some changes in 2023. What they will be, I'm not 100% sure. I know the talk is that the take homes that are now pretty regulated will be much more humane, I think is a good word to use. They won't be so restrictive. You'll have the alternative to give more take homes. And also that they may, they're working on trying to make, as I said, getting treatment out there, have access. And that access may be a provider writing the prescription for methadone for substance use disorder. And again, I say may, we don't know what those legislation will be. It's not going to get rid of methadone. It's not going to stop OTPs, but it's going to change the way we do things, which is what we've done all along. We've changed our access and we've changed the way we've done, and we're progressing. So I'm looking forward to some progression next summer 23, but my crystal ball isn't quite polished yet. What was the other part of that question? There was about methadone and
how are the decisions to switch made?
Good question. Most of the time, my patients who switch are just tired of coming to the program every day. There have been model clients, model, we call it patients, who've done very, very well. And they just, it's a pain in the butt to come to the program all the time. So we do a transition. I don't mind if a patient's, still has some, I like them to be stable on their methadone dose and do really well. And then changing them from methadone stability to buprenorphine stability. That's what really my goal is, to help a patient who's doing well to stay well, but not have to come to the program. But it could be for other reasons too. I have one person who is going out of town. They're going to Europe. And he's got a job over there in Europe for a month that he says, I don't want to go on my methadone. So we worked on doing a quick conversion over it, and he went to Europe and on buprenorphine, which was easy to access in Europe rather than to be on a methadone program. So there's a couple of reasons that the switch, but mainly the biggest thing for switch is the patient's got to be vested to it. I don't want anybody to make a switch if they're not vested to it. They have to be part of that collaboration. And on that, I'm going to say collaboration is the name of all of us as nurse practitioners and providers in our treatment of patients.
Thank you so much, Marion. I know we are at 12:58. Do you have time for one more question?
Sure.
Okay, great. And before we do that, I know people probably have to log off. So once again, later today, you will receive an email that includes a copy of the slides, as well as additional information about Max resources, and a separate email with the evaluation link. Once you complete the evaluation survey, please allow 1 business week for your attendance to be processed, and that will also be sent to your email, that certificate. Marion, thank you again. And the last question we have here is, do you have patients on Suboxone that you only see monthly? And you may have touched on this a little bit.
Absolutely. When they're doing well, I don't mind seeing them every 2 months or every 3 months. I have a couple people that I've had them for so long. Remember, I've been here 28 years, but doing buprenorphine since 2016. They have been model. So I don't mind seeing that really stable patient, just like you do your diabetic, who's very, very stable. Come back and see me again in 3 months. There are some people who I see every 3 months. Most of mine are right now we do a face-to-face 1 month and do a telehealth the next month. That's what we've been doing for COVID time. And so we see them every other month. But I don't mind, and a couple people, we see them every second month. So yes, treat your patients with dignity, like they have the disease that it is, substance use disorder, and with the respect of taking care of your patients.
Awesome. Thank you so much, Marion. Happy Nurse Practitioners Week to everyone who is still online with us. Please keep in touch with Max. Feel free to call us with any other questions. If you would like to speak specifically with Marion, you can let us know and we're happy to connect you with her. Thank you all again for being online for this whole time. The recording will be up on our website within 1 business week if you ever want to come back to today's talk. Other than that, please feel free to log off, and thank you again. Okay, I'm just saving the chat and making sure that everything with the meeting is closed out properly, but Marion, feel free to log off. I'm about to end the meeting for everyone. And let me know if there's anything else I can do for you.
No, thank you, Bridget.
Yeah. Have a
Bye.
good afternoon.
Bye.